gets drained out. So that portion, that working for resorption continues for about 3 weeks. After the third week, bone formation happens. During that bone formation, it can go up to 3 months also. Bone deposition is happening, and during this time, we already fixed the teeth. Function is also happening. So there is no loss of mineralization. The bone mineralizes and it will reach a stage of dormancy where you are finding this. Can you see that white line around the threads of the implants? Okay, that is a very, very important finding. I need to see that one. Once I see that, for the next 2 years, it has reached a stage of dormancy and it is staying there, which means occlusion has settled in. Patient is having a certain type of function, he is having a certain type of masticatory movement. That movement, we are very clear that we want to have a bilateral equal occlusion with a lateral pattern of chewing. The patient has to equal occlusion when he comes into centric, and when he is going into chewing the food. Have you seen the cows are chewing like this? It's a rotatory movement. The lateral pattern of chewing has to happen. So which means the occlusal morphology of the teeth will have only a minor morphology. It will not have very sharp cusp. This is very important. That's another topic to be discussed. That's a different subject by itself. But what happens? Resorption, activation, resorption, formation. After the formation, there is mineralization. After the mineralization, it has to be in a dormant state. Now, let me go back to the strategic implantology. The positions is 7-3-3-7, right? So, the moment I am going to place it in an area where there is a flexure of the bone, or in the floor of the sinus where the sinus has pneumatized, then what happens? That implant is already not engaged in firm bone, or that implant in the mandible is in a region where there is flexion of the bone. That region, it will not reach a stage of dormancy. Remodeling the bone activity, bone should not go into any metabolic activity at all. The main idea of using cortical implants is the cortical bone has very less metabolic activity, very less blood supply. Cancellous bone has massive blood supply. We don't want to go into the blood supply region at all. We want to go in a region where it is like a wax, where it is like a concrete. Just simply engage it. The stem of the implant, in a few months' time, 3 months later, it will osseointegrate. So does it osseointegrate the cortical implant, the polysurface implant? Of course, any biocompatible material will osseointegrate. Okay, so the lock which happens by what we call as the osseofixation is followed by osseointegration. Osseofixation is a macromechanical lock. The biologic answer of the body to that implant is osseointegration. That will happen subsequently. So when you look at the bone's nature, when there is a fracture and there is an immobilization, you will notice always the hand becomes thinner and smaller. If somebody's leg is broken and he is hanging, that leg is used to be hung in those days. That leg itself will become very, very thin and small. So there is wasting. The muscle gets wasted, the bone loses mineralization. According to the Wolff's law of transformation, that mineralization of the bone transfers to another region where it is useful. So if you look at the oral cavity, let us say this side is edentulous and this side is having 3-4 teeth. Is chewing this side. Obviously, this side will be lesser mineralized bone compared to this side where he is giving function. This concept is called as the 0-1 property of the bone, or the checkerboarding effect. One portion is mineralized, next to it is not mineralized, next to it is mineralized. Hence, you will have the bone which is having a slight amount of elasticity. Imagine a bone which is completely mineralized all over, it will fracture. That is how osteoporosis happens. It becomes very, very brittle bone. We don't want that. Always always the bone maintains this 0-1 capacity. Bone responds with always serious remodeling when there is a very high load, which is overload osteolysis, or when there is zero load, there will be disuse atrophy. Okay. It should be in between. When you compare osseointegration to osseofixation, please have a look. Implant is placed and there is a healing period. During the healing period, automatically there is a disuse atrophy, and when you apply the Wolff's law, the bone will respond with remodeling of the bone. The other side is fixation. When you fix it with a bicortical screw, there is no immobilization, which means you put the implant and I am putting a crown on top of it and I am loading it immediately. There is function on that implant. That doesn't mean the earlier ARF sequence doesn't happen. ARF sequence is the bone biology, it is continuing to happen, but by virtue of engaging the second cortical. That is why it is imperative that it goes into the second cortical. If it is not in second cortical, why it will fail? Because this will happen. Cancellous bone. ARF sequence is happening, but this ARF sequence is not happening inside the cortical bone because there is very, very less metabolic activity there. It is just simply sitting there by making a smaller osteotomy and putting a wider implant. So I have just simply crushed the bone and put it there. So how much can you crush the bone? Can I simply make a 2 mm hole and put a 10 mm implant? No, because there will be compression necrosis. This compression necrosis is a different subject by itself. That happens during the placement of a conventional implant also, when you place a compression screw. So again I will discuss that also. Okay, so when there is no immobilization and you are loading immediately, the bone responds. Although healing has not happened, you imagine the implant, okay? Bone is there. Inside the bone, I have made a hole of 2 mm. After that, I am taking an implant which at the thread of the tip of the implant is a 3.5 diameter, 3.6. Stem is 2 mm. What is happening when I am driving it inside is smashing the bone and going inside. So the 2 mm osteotomy from the top till where it engages has already become 3.6. Okay. The stem of the implant is only 2 mm. There is a space between the bone and the implant interface. Only the tip of the implant is engaged inside the desired area. Suppose in the mandible I want to engage the lingual cortical, or I want to engage the buccal cortical, or I want to engage the symphysis region. That is secondary. Now, after I did the drilling, threaded portion has gone inside, it has compressed the bone. But the rest of the shaft of the implant, there is a gap between the bone and the implant itself. That gap between the bone and the implant, when you are giving the load, there is a micro vibration which is called as the isoelasticity of the implant. This elasticity promotes bone growth and formation around the stem of the implant or the shaft of the implant, and it forms a very close layer leading to a dormant situation. That is the advantage of using a cortical implant in regions where you have massive bone, you have less bone, you have zero bone. It doesn't really matter, because